Hello everyone, welcome to another session of Next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on a very important topic which is referred pain, the questions on the diaphragm, the questions on patent ductus arteriosus and the neurovascular bundles in the ribs. So starting with the first question, a 62-year-old male with a history of hypertension, diabetes and smoking presented to the emergency department with a severe retrosternal chest pain that started 30 minutes ago while he was watching television. He described the pain as crushing and squeezing, but shoulder in aspect of the arm and jaw. He also reports diaphoresis, nausea, and mild shortness of breath. On examination, the BP is found to be slightly elevated. The heart rate is slightly elevated, but it is regular. Respiratory rate is near normal. On the ECG, you are getting ST segment elevation in lead 2, 3, and AVF, and troponin I is also positive. So, on the first look, it appears like to be a question asked from medicine related to inferior wall MI. But when you continue with the question, which of the following best explains the mechanism of referred pain in this patient condition? Actually, this is a question asked from anatomy. That means they are asking about the referred pain. Now, all of you know that referred pain occurs when a visceral pain misinterpreted as a somatic pain due to shared and spinal cord levels. You know, the heart, it is responsible for receiving the sensory innervation from the autonomic nervous system, especially the sympathetic afferents that enter the spinal cord at the level of T1 to T4 level. On the other hand, medial cutaneous nerve of the arm, this one, and the intercostobrachial nerve, that is T2, also converge at the same level, that is T1 to T4 of the spinal cord, carrying somatic sensory input from the chest, inner arm, and the shoulder. So, because visceral and somatic afferents, they synapse at the same spinal segment, so the brain it misinterprets the cardiac pain as it is originating from the skin and the muscles of T1 to T4 dermatomes. So this is the mechanism for the referred pain. And obviously, look at the regions of the pain and the dermatome levels. Like retrosternal chest pain is because of the T1, T4 dermatomes. Left shoulder and inner arm pain is because of T1, T2 dermatomes. The jaw pain and the neck pain is again because of T2, T3 dermatome. While the epigastric pain, which is very commonly seen in case of inferior wall MI, is because of T6 to T10 dermatomes. Now, although it is slightly difficult for us to understand, but it is important for us to remember the table which summarizes the key locations where the pain from the internal organs is perceived at a distant sites due to viscerosomatic convergence. So, where the afferent visceral and somatic nerve fibers share uh, spinal cord segments. So, this table is particularly important because, as we know, that the myocardial ischemia, the referred pain, which is the shoulder, left arm, jaw, and epigastrium, and the mechanism behind is that because it shares the spinal segment from C5 to T1. Similarly, in case of kidney, where there is nephrolithiasis, the pain of pyelonephritis, it is observed in flank, lower abdomen, groin, and testicles because of the involvement of T10 to L1 dermatomes. The spleen, or the rupture of the spleen, or the infarcts of the spleen, which is also known by the name of Care sign. This question has been asked multiple of the time. The pain is experienced in the left shoulder because of the phrenic nerve involvement. As far as the endometriosis, the fibroids, or the labor pain in the uterus is concerned, it is experienced in the lower pain, lower back, and the sacrum because of T10 to and L1 dermatomal involvement. Although it is a long table, but the referred pain questions are very, very commonly asked, particularly the visceral pain. Now, back to the question, which of the following best explains the mechanism of the referred pain in the patient's condition? Now, if we look at the option one, that means stimulation of the phrenic nerve causing diaphragmatic irritation. You know, the phrenic nerve irritation, it causes referred pain to the shoulder, but it is not seen in the myocardial infarction. It is best seen in pericarditis, peritonitis, or even diaphragmatic irritation. It is not classically seen in case of myocardial infarction, right? And here, the features of inferior wall MI are classically present. So this option can be ruled out. If you look at the option number C, that direct ischemic involvement of intercostal nerve 1 to 4. You know, intercostal nerves are somatic, whereas the myocardial ischemia is mediated by visceral sensory afferent. So intercostal nerve involvement occurs in rib fractures, pleuritis, the herpes zoster, but not in MI, which is given in the question. So option C can also be ruled out. After that, hyperstimulation of the vagus nerve, leading to the referred pain in the left upper limb. The vagus nerve, it carries the parasympathetic innervation, but it does not transmit the pain signals from the myocardium. So vagal activation in MI, it might cause nausea, bradycardia, and hypotension, which is known by the name of basal-gyrus reflex. So what you are left with as the answer is the convergence of the visceral and somatic sensory fibers in the spinal cord at T1 to T4 level. This is what we have studied and understood also. So hope everything is clear related to this first segment of our question, that is referred pain. After that comes a question on a 55-year-old male with a history of chronic GERD presents with a burning epigastric pain, especially worsening at the night after meals. He reports occasional regurgitation of the food on the chronic cough. The physical examination epigastric tenderness is noted. The barium swallow study shows a hiatal hernia, so it has already been mentioned in the question, where the part of the stomach has herniated into thoracic cavity through the esophageal hiatus. Which of the following diaphragmatic opening is most likely involved in the condition? So obviously, it is a prototype sort of a question where it is not a question related to the surgery. It is not a question related to the disease. It is a question which is related to asking about the diaphragmatic opening. So straightforward question. You already know the answer. Answer for that question is the esophageal hiatus at the level of T10. So let us talk about these diaphragmatic opening. Now, first is the caval opening, through which the inferior vena cava and the right phrenic nerve passes, and this opening is at the level T8. Then the another opening is esophageal hiatus. The structures that are passing through are the esophagus, the vagus nerve, and the left gastric artery branches. And the level is the vertebral level T10. And finally is the aortic hiatus. The structures which are passing through this are the aorta, the thoracic duct, and the azygous vein. And the vertebral level is T12. So these are the openings or the hiatuses in the diaphragm over which multiple questions are asked repeatedly. So as we have just talked about the caval opening, so what is the structures that are passing through this? We have already talked about this, the inferior vena cava and the right phrenic nerve. But what is the clinical importance? It does not dilate easily due to its firm attachment to the central tendon. So what happens in case of inferior vena cava congestion? How does it happen in case of right heart failure? Because of no dilatation. So it results in hepatic congestion and pedal edema. So that is the clinical significance related to right heart failure. Next, esophageal hiatus. Now, what is the clinical significance? We have already talked about the hiatal hernia, the GERD due to impaired lower esophageal sphincter function, and the achalasia, which is impaired esophageal motility at T10 level because of this opening at the vertebral level. And finally is the aortic hiatus. We know the structures which are passing through this are the aorta, the thoracic duct, and the azygous hemizygous veins. The clinical importance is the aortic aneurysm, which can compression syndrome in posterior mediastinum, and the thoracic duct injury at the level of T12 can lead to chylothorax. You know that it is a milky pleural effusion due to the leakage in the lymphatic systems. And aortic dissection type B, which occurs at the level of the aortic hiatus again. So these are the clinical associations through which the question can be framed in your examinations. So obviously, why, if we go back to the question, that why not the other options like caval opening, inferior vena cava opening at T8, it is responsible for transmitting the venous blood. So it is not involved in hiatal hernia. Aortic hiatus at the level of T12, this one, aortic hiatus transmit the descending aorta, azygos, and the thoracic duct, not the esophagus. So aortic aneurysm would be expected had there been a abnormality at this level. Finally, the sternocostal triangle is a minor opening that transmit lymphatics and small vessels, and it is not responsible for transmitting the esophagus. So that was a straightforward answer. All was required for you to remember about the hiatuses, their possible clinical significances, and the structures which are passing through these hiatuses. Now, coming on to a very important topic, that is patent ductus arteriosus and the associated coarctation of the aorta from the anatomical perspective. Let's read the question first. A 7-year-old boy is brought to the pediatric cardiology clinic with a complaint of fatigue, shortness of breath during exertion, and the leg pain while exertion. Now, his blood pressure in the upper limb is 160 by 90, which is high, and is different from that of the lower limb, which is 80 by 50 and is low. A continuous murmur is heard over the interscapular region. The radial pulses are strong and bounding, while the femoral pulses are weak and delayed. A chest X-ray shows rib notching and figure of three sign, and on that basis, you have to identify that what is the condition the patient is suffering from. Now, we already are aware of the fact that the patent ductus arteriosus is a congenital heart defect where the ductus arteriosus it fails to close after birth, allowing abnormal left to right shunting of the blood from the aorta to the pulmonary artery. However, PDA, that is patent ductus arteriosus, is commonly associated with coarctation of aorta. That means narrowing of the aortic lumen at the site of the ductus arteriosus, and here exactly where the problem arises. You see, coarctation of aorta is postductal. It is not much of a problem because it is located after the ductus arteriosus. It will result in the development of the collateral circulation. So there will be a development of the collateral circulation, and it will result in the upper limb hypertension and rib notching. So collateral circulation can develop in case of postductal coarctation of the aorta. What happens in case of preductal one? That before birth, all of us know that the fetal circulation it functions differently due to the presence of the patent ductus arteriosus. So what happens is oxygenated blood from the placenta enters the right atrium, through that the right ventricle, through that the pulmonary artery. So in normal fetal life, most of the blood is shunted through the patent ductus arteriosus to the descending aorta, which is responsible for supplying the lower body. This is normal till birth. Now, since the lungs are non-functional in utero, so PDA, that means patent ductus arteriosus, is essential for maintaining the systemic circulation to the lower body. But what happens once there is a birth of the child? So after birth, several physiological changes occur. The lung expands, pulmonary vascular resistance drops, the PDA starts closing in response to the higher oxygen levels and decreased prostaglandins. So as a result of which, if the baby is normal, then aorta starts delivering the blood to the lower body. But in case of preductal coarctation, which could be associated with this patent ductus arteriosus, the aortic narrowing, it prevents the blood flow from reaching the lower body, and it becomes PDA dependent. So this is the reason why in case of a child who is suffering from the preductal, that means infantile type of the patent ductus arteriosus or the coarctation of the aorta, before the ductus arteriosus, there is a coarctation, and it will result in the blood flow to the lower body. It depends upon the patent ductus arteriosus, resulting in the clinical features like cyanosis, heart failure, and lower limb hypoperfusion. So that is the major difference in between the two. If you want to identify it in the question related to what we have talked about, that why postductal coarctation of the aorta is the correct answer, because upper limb hypertension and weak femoral pulses are mentioned in the question. Now, rib notching, which is seen on the x-rays, which can be clearly seen on the x-rays over here, it is due to the collateral circulation through enlarged intercostal arteries is a feature which is presented over here. Now, figure of three sign, which is aortic indentation with post-stenotic dilatation, is also a feature which is mentioned over here, right? And childhood presentation with exertional leg pain due to poor lower limb perfusion. So that is the reason why postductal coarctation is the correct answer for this question. Why not the other options? You see, preductal coarctation of aorta, so it occurs in neonates, not in case of a 7-year-old child as it is mentioned over here, and severe cyanosis and heart failure, not the hypertension and rib notching. So it is ruled out. Now, why is it not interrupted aortic arch? Because it will lead to complete discontinuity of the aorta. So it is lethal without immediate surgery, and no such features of extreme cyanosis or shock at birth are presented to you in the question. So it is also ruled out. Takayasu arteritis, as you already know, that it is presented in young adult females, not in case of a child, and it causes absent pulses in the upper limbs, but this patient has a strong radial pulse mentioned in the question. So this also is obviously not the answer for this question. In order for you to identify the questions related to coarctation of aorta in future, you have to remember this table, that age of presentation in case of preductal is neonates, while in case of postductal it is children. The ductal arteriosus is patent because it is the PDA dependent blood flow to the lower limb, while it is closed in case of postductal. The blood flow to the lower body, as we just have talked about, it is dependent on the PDA, while it is dependent on the collaterals via the intercostals. The leg perfusion, there will be severe ischemia and cyanosis because of limited blood supply, and that too deoxygenated one. While the weak pulses and the claudication is the feature in case of postductal one, and rib notching figure of sign is a feature of postductal coarctation of aorta and not that of the preductal ones. So these are the findings you have to remember in order to identify and mark the question related to coarctation of aorta. Another very important practical question for you is related to the neurovascular bundle in the intercostal region. So the question is that during chest tube insertion for a patient with a large pleural effusion, the physician must take precautions to avoid injury to the intercostal neurovascular bundle. Which of the following is the correct anatomical site for chest tube placement in order to minimize the risk of neurovascular injury? And here there are four options provided. Now you already know that the intercostal neurovascular bundle, that is intercostal vein, intercostal artery and the nerve, it runs along the inferior border of each rib within the costal groove. So in order to provide injury to these structures during chest tube insertion, the tube should be placed just above the upper border of the rib. So that is the ideal site. So it is chosen in the intercostal space in order to avoid injury to the neurovascular structures. Now placing the tube at the lower border increases the risk of puncturing the vessels and the nerve, potentially causing hemorrhage or a nerve damage, and that is the reason why option A is ruled out. And B, in the middle of the intercostal space, it increases the risk of trauma to a smaller collateral branches, which could be there in between. So it is also ruled out. Then finally, at the midline of the sternum, they are incorrect as they do not provide access to the pleural space. So this is just for filling the options. The correct answer for the question is just above the upper border of the rib in a chosen intercostal space. What does it mean? That if you have chosen the space to be 4 or 5, that means intercostal space 4 5, then you have to go with the upper border of the lower limb. So hopefully everything is clear related to this session. Hope the session was helpful to you. All the best for your future examinations.